So Jill Gallaher is at Moffitt. It's a friend colleague of mine at the IMO, and she did her PhD in biophysics at East Carolina University, but she's been working at Moffitt together with Sandy Anderson for quite a few years now, and she's been creating some great spatial models of cancer in many different contexts and situations and applications of treatment. And clearly, her work is really sort of relevant to this meeting. So I'm just looking forward what you have to present today, Jill.
Thanks. So looking here now at dynamics of spatial systems in the metastatic setting is what I'm going to look at. So, often we think about adaptive therapy and the question is, do you kill or do you control? And you've kind of got this black box of cancer and you try to define what the cancer is. You try to define what control might be. But, I think one thing to really look at is that adaptive therapy in its first cycle can also be not just about therapy, but about characterization of the disease state. So trying to better define this black box of cancer. And especially when you're talking about metastatic cancer. So it's not, just this, you have metastases or not, there's all in between states and all sorts of nuance to what metastasis means. So, metastatic seeding and timing can affect the different sizes of the metastases. You can have heterogeneity within the primary tumor, giving rise to heterogeneity within the metastases. You can have heterogeneity within the metastases, and there can be seeding from mets to mets. So now, when you start to treat this system, maybe you even only observe some of these larger tumors. So, I think that adaptive therapy can then be used to further characterize what we have going on here. But often, like I said, metastases are just considered as being present or not. There's this one paper here on the left that talks about better staging metastases, and that it's difficult to define because you're describing the process and the outcome as one. Often we're not distinguishing between different grades of metastases, whether it's circulating tumor cells, different amounts of metastases that show up on imaging, and often just kind of boil down to this biomarker that's in the blood. And then furthermore, not just characterizing metastases as a single time point, but it also has the ability to change over time. So we can observe several markers, whether it's in the blood or the imaging, that this is an ongoing process and we can continue to monitor it. So what I'm going to do is look at this spatial model setup where I seed several metastases, each within their own individual domains. There's a growth period and a seeding period, after which there's a response time. I'm going to use the 50% kill before the drug is taken off, and that gives you one cycle in adaptive therapy. But each one of these metastases contains individual cells in an off-lattice domain, and they go through this process where first they could possibly have some random death, some cell turnover. They check to see if there's any space, and if not, they go into a quiescent state where they quit progressing through the cell cycle. Otherwise, they progress through the cell cycle until they're mature, so they have a certain timer specific to that cell, and then in which case they'll divide and create another cell. And so we're assuming here that the drug has to go through axon division for the cells to die. And you can kind of see a spatial layout of what this looks like within a single tumor during drug application. So you see there's a large amount of yellow cells. These cells are in this quiescent state because they have no space to divide. But then random death can occur wherever throughout the tumor. And then where those cells die within the tumor, they can also then repopulate. So you see a couple of green cells in there too. However, I'm also assuming that the drug can only get to these spaces on the edges where there's enough space that I'm assuming that they're on the edge and that drug can penetrate. And so that's why you see just the red cells where cells are dying on the edge there. And so the first question that we're asking here is, how does adaptive therapy, what affects adaptive therapy cycle dynamics? So here we're looking at this adaptive therapy trial data from the metastatic prostate cancer trial. And you can see a couple of patients here, what their PSA looks like over time. They have different cycles and fail treatment at different times. We can take all of these patients and line them up so that their switch point between on treatment and off treatment for the first cycle is shown in the middle here. And you can see that there's variation in the amount of time that the drug is on and then the amount of time it takes to regrow following that treatment period. And then we can place this into what I'm calling cycle space, where you see how the response time and the regrowth time for the first cycle looks like for each patient. And so you see with this adaptive therapy trial data that all of these patients fall within this kind of top left. Most of them fall within this top left area where the response time is shorter than the regrowth time. So we take the model and we go through most of these pretty sensitive parameters to the cycle times. This includes the total cell burden that we grow it to before we start treatment, the number of metastases, the sensitivity of the metastases, and turnover, leaving heterogeneity alone right now. And so what we see when you have to go through the cell cycle to be able to die, that you often get really long response times compared to the regrowth times. So your distribution of sampling through this space kind of gets shifted towards the middle and to the lower right. So and that's because some of these have really long cycle times. We're assuming that there's a trade-off between proliferation and resistance. And so that sensitivity that could be really low takes quite a while to go through the whole cell cycle to get hit by the drug in the first place. So if we then make this drug cell cycle independent, we see that we can have this death happen faster than the cell cycle, and you get something that matches a little bit better with these samples, these simulations falling onto the upper left corner of this cycle space. And so moving forward, we're going to use this drug to describe the rest. So next we looked at how burden and number of metastases affect adaptive therapy cycling. So here we're keeping everything constant except for the burden, which can vary between 2,000 and 150,000 cells, and metastases from 1 to 10 mets. And we see that the response time and the regrowth time are really high if you have a really high burden and a low number of metastases, and they're really fast if you have a large number of metastases and a low burden. And so we can plot this into the cycle space, and it fits really nicely along this line. And you can see that there is some of this correlation is apparent where you have this low burden and high number of mets and really quick cycles, and then the opposite with really long cycles for a low number of mets and a high burden. But there, it's kind of jumbled in there. So if we look a little bit closer, we can look at, say, 2 and 9 mets with a high burden, which is up top, and a low burden down below. And if we look at the adaptive therapy cycles here, and instead we're plotting the average number of cells per met, so we're not plotting the total burden, but basically taking the total burden and divided by the number of mets, we can see what these cycles look like. And so you see for these really large tumors, you have really long cycles. For the really small tumors, you have really short cycles. But this 2 and 3 in the middle have about the same cycles. And you can see that they have about the same size mets. So it's turning out that it doesn't really matter how many mets you have, but it's just about the sizes of those mets. And so we can plot that too in the same space, and we see that it fits really well, that it's really the size of the met. And we can plot this also with the age. So, I mean, the size is pretty much related to the age, but we can't really measure the age in real imaging. It's really even hard to measure the size of the mets in prostate bone scans. But either way, this seems to be pretty good trend that you have these younger and smaller tumors with shorter cycles and older and larger with longer cycles. So next we looked at how sensitivity and cell turnover affect adaptive therapy cycling. So now we keep everything constant except for these two things, remembering again that we have this trade-off with proliferation and resistance. And so we can look here again at response time, and we have to the left the less sensitive tumors, and to the right we have more sensitive tumors. So if we just focus on the bottom of the pink bars, this is when the treatment cycle is on. This is the width of it kind of describes how fast the response time is. So you can see that it takes longer for the less sensitive tumors to respond. That makes a lot of sense. But then if you look and see that it's a little bit shorter if you have this cell turnover. So, you know, as it was mentioned in Diana's discussion, that, you know, you can have this cell turnover and it kind of disrupts the spatial structure right at the edge. And so this kind of helps make it faster for this response time. And then we can look at the regrowth time. So because you have these less sensitive tumors corresponding to less proliferation, then it takes longer to grow back. So if we're just focusing on the white space between the treatments, you can see that it's a little bit longer on the left. And then furthermore, if you add in cell turnover, this basically just makes the net proliferation rate a little slower. And so it takes longer for the upper tumors there in the y-axis. So we can plot this in cycle space as well, and we see that as you increase sensitivity, you increase the cycles, both regrowth and response. And while you increase random death, then you increase the response time, but you make the regrowth time longer. And so next we wanted to look at how seeding and heterogeneity affect the observed burden, which is one more thing that we can look at when you're talking about a lot of hidden metastatic disease. So if you look, everything that I've shown before has been simultaneous seeding. So everything's been seeded and then you wait and then you treat. But it could be that you have sequential seeding, you have constant seeding from the primary, or it could be that you have some heterogeneity, and I wanted to compare these. And so when you really start to think about observing metastases, you have to think about imaging, and that there's going to be micrometastases that are below this threshold of visibility. And so when you compare the same burden of cells throughout all of these metastases, if you split that same burden amongst more metastases, you're going to get smaller tumors and most likely not going to be visible. And so here's kind of some distributions of these edges of tumors, what the sizes they are compared to this. I'm just making an arbitrary 10K cell threshold, which is this gray box. And so you can see that basically when you see them all at once and they're all homogeneous, that either they're going to be all visible or all invisible. And there's some on this line that are landing just right on that threshold. And so maybe some are visible and some are not. If then we have sequential seeding, you can see that the sizes of these tumors vary. And so some will be visible and some will be small enough to go undetected. And the same thing happens if you have heterogeneity amongst these metastases, and that, you know, it's practically indistinguishable whether it's, if all you could see was the sizes of these, whether it's due to sequential seeding or it's due to heterogeneity and this cost of resistance of these cells being seeded. But we can't observe this, of course. This is a model, so we can actually see where all these metastases, how big they are. But if we were to actually look at something that would be clinically relevant, then we can change this x-axis to be the number of visible Mets. And so what happens with these several scenarios that I've already shown you, I'm just showing you with a different x-axis. So these are the number of Mets that are actually visible. You start to cut off more of this right-hand side where you have more Mets, but because the burden is low or because they were seeded late, they are not visible. And so you have kind of this region where it could be that these larger, fewer Mets, what you're observing is actually what's there, but there's this whole line where you don't know exactly how many metastases there are. And so if you look at the patient data, and this is adaptive therapy patient data plus continuous therapy patient data, because this involves no dynamics, this is just a static feature, right? How many Mets do you have and what's your PSA? Then, it makes sense. It'd be nice and ideal if this is what happened right here in this blue circle, that you have Mets correlating with burden. And then, of course, it makes sense if maybe you have some early established large few Mets that have a really large PSA, but there's only a few there. But really what we can account for is that you have a large number of metastases and a low PSA. And there's various reasons why this could be so. There could be patient-to-patient variability in PSA. It could be that cells are not producing PSA, but that's an open question. And so I just wanted to kind of end on this last thing, that going a little further into heterogeneity and what that means for longer term dynamics and adaptive therapy. So if we look at this, going back to this intertumor heterogeneity, and we can treat both of these, we'll treat this single initial condition with both adaptive and continuous therapy. We see that continuous therapy does better, and this makes perfect sense because you need the spatial competition for adaptive therapy to work. So you can't just have resistant cells and sensitive cells. They actually have to be in direct spatial competition to have the intended effect. But what does work is when they are in direct competition, and so you can take this initial condition of intratumor heterogeneity amongst the Mets, and treat these with either continuous or adaptive therapy. And you can see that you do continuously select for these really resistant cells with continuous therapy, while you have some competition along the way that slows that down with adaptive therapy. And so just to conclude, this cell cycle independent drug leads to these shorter response times than regrowth times that you don't see if the drug is acting through the mitosis. And then the cycles are kind of correlated with burden and number of Mets, but there's clear trends associated with size, age, sensitivity, and turnover. I think it's important to note that micrometastases can be there without being observed, that if they're smaller than the imaging threshold, they can go undetected, but they're still contributing to the tumor burden. And I think, knowing that you do have to have this spatial competition for adaptive therapy to work, it could be that you could better characterize metastases before you decide which treatment to use. And just, reiterating that characterizing metastases only as a binary state is not adequate. And so I think we can do better to describe the disease before we treat it. And so I just wanted to thank Sandy and Maxie, Jeff, and Mark have been really influential in shaping this. And of course, Bob and Jing Song for the data and their continuous feedback.
So great talk, Jill. Very impressive work, and we have at least some questions and maybe a bit Yeah, no, we have plenty of time, which is great. So if people have more questions, please use the Q&A box to send them to me so I can read them over. So Carlo Male has this question for you. Is the association between response and number of mets due to the delivery of the drug at the periphery?
Yeah, I mean, in a way, yes. So it's also how I sample my space. So I've chosen here to have a cap on the burden, and I'm not sure that that's the case, because this is a spatial system with many cells within several mets. It's computationally difficult.
Mm-hmm.
So there is constraints on the the sampling space. But yes, in a way, yeah, as you have smaller tumors, you do have more surface area, so it's easy to quickly respond. So it's more about the size of the tumor, but you're taking the same burden and distributing it amongst many mets versus comparing it to the same burden of just a few mets. So I think it boils down to, yes, you're correct, but it's basically the size. But what surprised me, and I mean, it makes perfect sense, that it doesn't matter how many you have if they're completely the same, that they all kind of respond. So 10 mets would just respond with the same cycle as one met.
Thank you. So next one is from Fred Adler. Impressive and very interesting analysis. If I understand correctly, the models track two fixed cell types. If we look at cycles over time in a single patient, could we infer anything about evolution? For instance, the decreased cost of resistance?
Yeah. And it's really kind of my hypothesis that I think it's not actually an increased cost of resistance, but it's a decreased cost of resistance. That I think it could be that we're starting with a cost of resistance and it's being lost along the way. But yeah, I mean, one thing that I see is that as these model tumors fail, that you get longer cycles, and I don't think that's what's happening in the patients. I think you might get slightly shorter cycles, and it could be that we're considering different resistance, different types of resistance. So it could be drug induced. It could be, it just could be selection over time for a different type. And so yeah, I think I don't know if I answered the whole question, but did I miss something? But yeah, I think we can learn a lot more about the cycle, the movement through this cycle space over time. And it's not really clear. We've got 16 patients. Some only have one cycle, and then that kind of drops down and how much information you can look at and really draw conclusions from. So I think we're still learning. I think as these more trials come out, I think it'll be really nice to learn more information from it.
Very cool. Next one is from Hitesh Mistry. We know that for abiraterone, there are other numerous prognostic factors that correlate to outcomes, such as alkaline phosphatase, lactate dehydrogenase, hemoglobin, patient age. Could they easily explain the discrepancy between initial PSA and the number of mets? This might be, yeah, I don't know if this is something you can talk with your model, or if this is something that if you feel like you can answer to this, that's great.
I mean, I'd like to answer it. Well, but I don't know about those in particular. But I mean, I will say generally that I think there's definitely a lot of information in the blood that we're not getting from just looking at PSA. Just looking at testosterone levels, how they change, looking at maybe androgen receptor in the blood. There's tons of things there that can start to help us define heterogeneity within the system, or even just an initial state, even if you don't look at it over time. So Yeah, I mean, it's hard to tell. There's a lot of little moving parts, but I think that we're just not looking when it comes to metastatic disease. I think when you know, it's easy to have a place to look. So when you have the primary, you can take that information and you can extrapolate to the metastases. But I think we're still learning how to use that information that may be less well connected to the actual disease. And you know, it's kind of, maybe it's connected, but and in this information, you know, some of these biomarkers are not routinely collected, so it's hard to learn from.
Cool. Yannick has a question as well. I think you said that when the tumor is more sensitive, then not only the treatment phase, but also the regrowth phase is quicker. Is this correct? If so, does this depend on your definition of sensitivity?
So yeah, when they're more sensitive, they respond quicker and they regrow quicker. Yeah, this has to do with the trade-off. So because the cells, let's say if they're 100% sensitive, they have the fastest response rate, but they also have the fastest proliferation rate. So they're following that. Did I answer that?
Yes, but he's also asking, I didn't finish his question, for your definition of sensitivity. Like, how do you define sensitivity in your model?
Yeah, so in this model, it basically, I've got for the cell cycle independent drug, there's an exponential decay as to how the resistance level correlates to the probability of death. And so this basically affects, you know, a factor in front of it. This affects kind of the exponent. So as you're, because this is happening at every time frame. So as you get more resistant, you have less response to the drug.
One final question from, I think you might know this person, certain Alexander Anderson. Mm-hmm. Says, do you consider resistance as a continuous trait as opposed to a binary one? Do you think that distinction is important?
Yeah, I do. I mean, I think, you know, our previous work on this, I mean, you can see how different doses of drug at least can start to select for slightly less resistant cells. I don't know. I think simplicity-wise, it's not always necessary to look at, but I think here you can start to see a little nuance as to how just changing a little bit of sensitivity or a little bit of proliferation can start to shift you through the space. So I do think that heterogeneity is important. You know, it depends what question you're asking. And so I think in this case, trying to navigate the way through this cycle space, it does make a difference.
So basically, it's a simplification you can live with because of the question. Mm-hmm. Cool. All right. Thank you very much, Jill. And